Welcome to this journey through one of the most chilling medical mysteries in American history. Tell us where you're watching from now, because this story will haunt you in a way few other accounts can. We're about to delve into a case that shattered the sacred trust between healer and patient, where a trusted nursing assistant defied all expectations of mercy and left a legacy so disturbing that it forced an entire medical system to confront its darkest vulnerability. It was the year 1987. The Cold War was entering its final, uncertain phase. President Reagan stood at the Brandenburg Gate, demanding that Gorbachev tear down the Berlin Wall. Wall Street faced Black Monday, the largest single-day stock market crash since 1929. America was consumed with the Iran-Contra hearings, the AIDS crisis, and a growing unease about the institutions it had always trusted. In Prince William County, Virginia, just 30 miles southwest of the nation's capital, the situation seemed far removed from these global concerns. This was suburban America at its most ordinary, a landscape of shopping centers and split-level homes, of hospitals and nursing facilities where the aging population sought care and comfort in their final years. But within the sterile corridors of one such facility, something unspeakable was occurring. Something that would not be understood for years. Something that transformed healing hands into instruments of death. This is the story of Orville Lynn Majors, though history would remember her by a different name entirely. The Angel of Death. Prince William County in the late 1980s existed in that peculiar American space between rural tradition and suburban sprawl. The old farmland was giving way to developments with names like Pleasant Valley and Meadow Ridge, sanitized versions of the wilderness that once defined this region. Strip malls multiplied along Route 1. Office parks sprouted near Interstate 95. The population was exploding as Washington, D.C. Workers sought affordable housing and safer neighborhoods, but pockets of the old Virginia remained. Small towns with main streets lined by brick buildings from the 1920s, churches with white steeples, VFW halls where veterans gathered, and health care facilities that served an aging population, people who had built these communities and now, in their twilight, needed round-the-clock medical attention. Vermilion Medical Center was one such facility. Not quite a hospital, not quite a nursing home, it occupied that middle territory of extended care. A single-story structure built in the early 1970s, it had the institutional architecture common to its era. Beige brick exterior, narrow windows, fluorescent lighting that hummed constantly, linoleum floors polished to a dull shine that reflected nothing clearly. The air inside always carried that particular scent, not quite antiseptic, not quite decay, but something in between. A mixture of industrial cleaning solutions, cafeteria food, medication, and the unavoidable smell of human bodies slowly failing. It was a smell that visitors noticed immediately, but staff stopped registering after a few weeks. It simply became the atmosphere they breathed, the environment they inhabited 8, 12, sometimes 16 hours a day. The facility specialized in respiratory care and intensive monitoring. Patients here were seriously ill, emphysema, heart failure, chronic obstructive pulmonary disease, complications from diabetes. They required ventilators, oxygen supplementation, cardiac monitoring, feeding tubes. Most were elderly. Many were on their final journey, and everyone understood this reality, even if it remained unspoken in the cheerful decorations, and Chinese letter, posters that adorned the walls. Death was not uncommon at Vermilion Medical Center. It was, in fact, expected. That expectation would become a perfect camouflage. The nursing staff worked in rotating shifts. 12-hour blocks that blurred together in the eternal artificial light. Day shift, night shift, weekend coverage. The work was physically demanding and emotionally exhausting. Patients required constant attention, turning to prevent bedsores, suctioning airways, checking vital signs, administering medications, responding to alarms that shrieked from monitoring equipment. And always, always, the presence of death. Not dramatic or sudden, usually, but slow and incremental. A patient who was alert last week, now confused. Someone who could eat solid food, now requiring a feeding tube. The gradual descent into unconsciousness, the labored breathing, the gathering of family members who kept vigil by bedsides, the final rattling exhalation. The nursing assistants bore witness to all of it. They were not doctors or registered nurses. They had less training, less status, lower pay. But they spent more direct time with patients than anyone else. They knew the patient's routines, their preferences, their personalities. They held hands during moments of fear. They offered comfort when families couldn't be present. They were there, day after day, shift after shift, performing the intimate labor of caring for bodies that were failing. It was sacred work, in its way. For most people who chose this profession, it was a calling, an act of service, a willingness to witness human vulnerability and respond with compassion, but not for everyone. Orville Lynn Majors began working at Vermilion Medical Center in 1986. She was 27 years old, a local woman, married, no children. She had completed her certified nursing assistant training and came with adequate references. Nothing about her initial presentation raised concerns. She was professional, punctual, competent with basic procedures. But something about her was off in ways that were difficult to articulate. Other staff members would later struggle to explain the unease they felt around her. She smiled at appropriate moments, but the smiles never quite reached her eyes. She spoke about patients clinically, without the warmth or personal connection most caregivers developed. When someone died, she displayed no emotional response, not sadness, not even the weary resignation veteran healthcare workers developed. Just nothing. She was always very controlled. One colleague later recounted, like she was performing the role of a caring nurse, but didn't actually feel any of it. During her first 6 months, the death rate on her shifts was unremarkable, within normal parameters for an intensive respiratory care unit. Patients died as they always did. Families grieved. Memorial services were held. The rooms were cleaned and prepared for new admissions. But in the spring of 1987, something began to shift. Patients on Majors' shifts started dying with slightly greater frequency. Not enough to trigger immediate alarm. These were critically ill people, after all, and mortality was expected, but enough that some staff members noticed. A patient who seemed stable in the morning would be dead by end of shift. Someone who had been improving suddenly crashed. Cardiac arrests increased. The incidents followed a pattern, though it would take time to recognize it. They happened when Majors was alone with patients. They happened during periods when supervisory staff were occupied elsewhere. They happened quickly, too quickly for the monitoring equipment to provide adequate warning, too quickly for intervention. And they happened most frequently to patients who were demanding, difficult, or required extensive care. An elderly man with dementia who shouted constantly and tried to remove his breathing tube. A woman with chronic pain who pressed her call button repeatedly throughout each shift. A patient who complained about everything: the food, the temperature, the way his pillows were arranged. They all died on Majors' shifts. In late March of 1987, a veteran nurse named Patricia Hendricks began keeping informal notes. She didn't think of it as an investigation, not yet. She simply noticed something statistically unusual and, as someone who had worked in healthcare for 23 years, trusted her instincts. Over 6 weeks, Hendricks documented 12 deaths on shifts when Majors was working. In the same time period, only 3 patients died when Majors was not present. The facility typically averaged 6 to 8 deaths per month. They were on track for nearly 20. Hendricks brought her concerns to the medical director, Dr. Raymond Foster. He was skeptical. "Patricia, you know how statistics work," he said, leaning back in his office chair, fingers steepled. "Random clustering happens. We've had busy months before, and these patients, you've seen their charts. They're extremely ill, multiple organ systems failing. It's actually surprising we don't lose more of them." "I understand probability," Hendricks replied, her voice calm but firm. "I also understand something feels wrong. The circumstances of these deaths. They're happening too quickly, without adequate warning signs, and there's a common denominator." "Be very careful what you're suggesting," Foster warned. "Accusing a staff member of wrongdoing is serious. We need concrete evidence, not a feeling." "Then let's look for evidence," Hendricks said. "Review the charts, examine the patterns. If I'm wrong, I'll apologize and we'll all sleep easier." "Doctor," Foster agreed, reluctantly, to a quiet internal review. What they found was disturbing. In case after case, patients who died on major shifts showed a similar sequence: sudden respiratory distress, cardiac arrhythmia, rapid deterioration despite intervention, death within minutes, hours. The medical explanations vary: pulmonary embolism, myocardial infarction, respiratory failure, but the pattern was consistent. Most troubling were the medication records. Controlled substances, particularly injectable medications like morphine and potassium chloride, were being accessed with unusual frequency during Majors' shifts. The documentation was technically correct, but the volume was questionable. Patients who had been receiving stable pain management suddenly required emergency doses. Cardiac medications were administered in situations where standard protocols didn't clearly call for them. It could all be explained away. Critically ill patients required aggressive intervention. Medical crises demanded immediate response. Majors was simply doing her job, responding to emergencies as they arose. But the sheer quantity was suspicious. In April of 1987, Dr. Foster made a decision that would prove both correct and tragically delayed. He contacted the Virginia Board of Medicine and the local sheriff's department. An investigation was opened. It would take 3 more months and 6 more deaths before anyone could prove what was happening in the quiet corridors of Vermilion Medical Center. Detective Michael Hargrove had been with the Prince William County Sheriff's Department for 14 years. He had investigated domestic violence, drug trafficking, armed robberies, and 2 previous homicides. But nothing in his career had prepared him for what he was about to uncover. Medical murders are different, he would later explain in testimony. The crime scene is everywhere and nowhere. The evidence is in blood tests and medication records. The witnesses are dying patients who can't speak, or family members who saw nothing unusual. And the suspect has legitimate access to everything they need to kill. Hargrove began with the medication logs. He requested complete records for every controlled substance accessed during the previous 12 months. He compared usage rates across all shifts, all staff members, all time periods. He looked for anomalies. They appeared immediately. During shifts when Orville Majors was working, controlled substance access increased by 43% compared to facility averages. During her shifts, emergency medication administration occurred at more than twice the normal rate. And during her shifts, Patient deaths exceeded the baseline by nearly 300%. The statistics were damning. But statistics alone wouldn't secure a conviction. Hargrove needed to understand method. How was she killing them? What was she using? How was she avoiding detection? He consulted with forensic pathologists and toxicologists. They explained what he needed to look for. Potassium chloride is nearly perfect for this purpose. Dr. Ellen Sawyer from the State Medical Examiner's Office told him. It's stocked in every medical facility. It has legitimate uses correcting electrolyte imbalances, certain cardiac conditions, but in high doses, especially administered rapidly through enroman 4, it causes immediate cardiac arrest. And here's the critical part. Potassium is naturally present in the body. After death, cells break down and release potassium, so post-mortem testing can't easily distinguish between natural levels and injection. Unless you're specifically looking for injection sites, testing within hours of death, you'll miss it entirely. How long has this been a known risk? Hargrove asked. Decades. Sawyer replied grimly. We call these angel of death cases. Healthcare workers who kill patients under their care. It happens more than people realize because it's so difficult to detect. Most facilities don't look for it until someone notices the pattern. By then, dozens might be dead. Hargrove felt a cold weight settle in his chest. Dozens. He requested exhumation orders for 3 recent victims, whose families agreed to additional investigation. The bodies were autopsied, specifically looking for signs of potassium chloride injection or other substances that could cause rapid death. The results were inconclusive. Too much time had passed. The evidence had degraded. They would need to catch her in the act. In late June of 1987, a surveillance operation began. It was delicate, complicated, and ethically fraught. They couldn't remove Majors from patient care without evidence to support termination. The liability risks were enormous. But they also couldn't allow her to continue if she was genuinely killing people. The compromise was increased oversight. Additional nursing staff assigned to her shifts, supervisors making frequent rounds, medication access monitored in real time. Security cameras installed in medication supply rooms, though, critically, not in patient rooms, due to privacy regulations. Majors seemed to sense the scrutiny. For 3 weeks, nothing unusual occurred. Patients on her shifts remained stable. Death rates returned to normal. Some staff members began to wonder if the entire investigation was a mistake, a case of seeing patterns where none existed. Then, on July 15th, everything changed. The patient was Gerald Hutchins, a 63-year-old man with end-stage emphysema. He had been at Vermilion Medical Center for 6 weeks. His condition was serious but stable. He was conscious, able to communicate despite the oxygen mask. His wife visited daily. He was expected to survive several more months, possibly longer. Majors was assigned to his care on the night shift. At approximately 2:15 in the morning, monitoring equipment in Hutchins' room began alarming. Cardiac arrhythmia, blood pressure dropping, respiratory distress. Majors responded immediately as protocol required. She called for assistance. She began emergency interventions. Other staff arrived within minutes, but by the time they entered the room, Gerald Hutchins was in full cardiac arrest. Resuscitation efforts continued for 42 minutes. They were unsuccessful. Hutchins was pronounced dead at 2:57 a.m. The official cause of death was listed as cardiac arrest secondary to respiratory failure, entirely consistent with his underlying disease. But nurse Patricia Hendricks, who had been part of the response team, noticed something that made her blood run cold. On the small table beside Hutchins' bed, partially concealed beneath a tissue box, was a syringe, empty. Uncapped, it should have been disposed of in the Sharps container immediately after use. Instead, it had been set aside and forgotten in the chaos of the emergency. Hendricks carefully retrieved it, handling it only by the plunger end, and delivered it directly to Detective Hargrove. The syringe was analyzed. It contained trace amounts of potassium chloride. A review of the medication logs showed that Majors had accessed the medication supply room at 1:53 a.m. 22 minutes before the alarms began. She had signed out a dose of potassium chloride, documenting it as being administered to a different patient on the opposite end of the facility. But that patient's medical record showed no order for potassium, and nursing staff confirmed they had seen the patient sleeping peacefully throughout the night, undisturbed. Majors had stolen the medication, falsified records, and used it to kill Gerald Hutchins. Finally, they had evidence. On July 16, 1987, Orville Lynn Majors was arrested at her home and charged with first-degree murder. The investigation that followed would reveal the full scope of her crimes. The Prince William County Courthouse had never seen a case like this. The trial of Orville Lynn Majors began in February of 1988, 8 months after her arrest. The prosecution faced an enormous challenge, proving murders that had been designed to look like natural deaths, using medical procedures that had legitimate purposes, in a setting where death was routine. Lead prosecutor Catherine Brennan knew they needed more than the single proven case of Gerald Hutchins. They needed to establish a pattern. They needed to show this wasn't an isolated incident or a tragic mistake, but systematic, deliberate murder. The state will prove, Brennan told the jury in her opening statement, that the defendant, Orville Lynn Majors, used her position of trust as a healthcare provider to murder at least 6 patients under her care, and possibly dozens more. She selected vulnerable victims who couldn't defend themselves. She used her knowledge of medications to induce deaths that appeared natural. And she did this repeatedly, methodically, over a period of at least 14 months. The evidence presented was overwhelming and disturbing. Forensic accountants traced medication access patterns. During Majors' shifts, controlled substances disappeared at rates that vastly exceeded medical justification. Specifically, potassium chloride, morphine sulfate, and digoxin, all medications that could induce death if misused, were accessed far more frequently when she was working. Medical experts testified about the victims. They explained how each death, viewed in isolation, appeared consistent with the patient's underlying conditions. But examined collectively, with knowledge of medication access patterns, a different picture emerged. Patients who should have had hours or days of decline instead crashed within minutes. Symptoms appeared that weren't consistent with their primary diagnoses. And the timing correlated precisely with Majors' work schedule. Perhaps most damning were the psychological elements. Colleagues testified about Majors' demeanor, her lack of emotional response to death, her tendency to volunteer for the care of the most difficult patients, not out of compassion, but seemingly to have access to them. Her detailed knowledge of exactly how much medication would be required to induce cardiac arrest without leaving obvious traces. She talked about it once. A nurse named Jennifer Morrison testified, her voice shaking. "We were in the break room discussing a patient who was being verbally abusive to staff. Someone joked about putting something in his Roman for to calm him down. Dark humor, you know, the kind of joke stressed medical workers make, but Orville didn't laugh. She said, 'You'd want to use potassium, fast-acting, hard to detect. Looks like the heart just gave out.' We all went silent. She noticed, and Added, not that anyone would actually do that, obviously. But the way she said it, it wasn't theoretical, it was knowledge. The defense strategy was to paint Majors as a dedicated professional overwhelmed by a difficult job. Her attorney, Thomas Ridgefield, argued that the death rate patterns were coincidental, that Majors had been assigned to the sickest patients precisely because of her competence, and that prosecution was engaged in statistical manipulation. Correlation is not causation. Ridgefield told the jury, "My client has devoted her career to caring for the dying. She has held their hands, comforted their families, worked double shifts when the facility was short-staffed, and now, because some patients died on her watch, patients who were already dying, she's being accused of murder. This is not justice. This is scapegoating." But the defense couldn't explain the syringe found in Gerald Hutchins' room. They couldn't explain the falsified medication records. They couldn't explain why Majors accessed potassium chloride and then documented giving it to a patient who never received it. The trial lasted 6 weeks. 43 witnesses testified. Hundreds of pages of medical records were entered into evidence. The jury deliberated for 11 hours. On March 23, 1988, they returned with a verdict. Guilty on 6 counts of first-degree murder. The courtroom erupted. Family members of victims wept. Several people had to be escorted out as they shouted at Majors, their grief and rage finally finding a target. Orville Lynn Majors showed no emotion. She sat perfectly still, hands folded on the table in front of her, staring straight ahead. At sentencing 2 weeks later, Judge Harold Pemberton addressed her directly. "You violated the most sacred trust that exists in our society," he said. "Patients in your care were completely vulnerable. They depended on you for their survival. They trusted you to ease their suffering, not to end their lives. Instead, you became an angel of death, deciding who would live and who would die based on your own twisted criteria. The law provides only one appropriate punishment for such heinous crimes." He sentenced her to death by lethal injection, a bitter irony that was not lost on anyone present. Orville Lynn Majors was executed on November 8, 1995, at the Greensville Correctional Center in Virginia. She was 36 years old. She never admitted guilt, never showed remorse, never explained her motivations. In her final statement, she maintained her innocence. "I cared for my patients. I did everything I could to help them. History will judge this case differently than you have." But history has been clear in its judgment. After her conviction, Vermilion Medical Center conducted an exhaustive review of deaths during the period of her employment. They identified at least 67 deaths that occurred on her shifts with suspicious circumstances. The true number of her victims will never be known with certainty. Many patients were cremated. Medical records were incomplete. Families had moved on, accepted their losses as natural. The case prompted sweeping changes in healthcare protocols nationwide. Medication tracking systems became more sophisticated. Multiple-person verification requirements were implemented for high-risk drugs. Surveillance of mortality patterns became standard practice. Facilities developed psychological screening tools to identify staff members who might pose risks. But the deeper questions remain unanswered. What drives someone to kill the helpless? What psychological fracture occurs that transforms a caregiver into a murderer? Experts have proposed theories. Some point to a personality disorder, a fundamental inability to empathize with others' suffering. Some suggest a pathological need for control, for holding the power of life and death. Others theorize about accumulated stress, burnout, and a gradual desensitization that crossed into something darker. Majors herself provided no clarity. Psychiatric evaluations during her trial found her competent, but revealed little about her internal world. She was intelligent, articulate, and completely opaque. Whatever motivated her actions remained locked inside her mind, and she took those secrets to her grave. The story of Orville Lynn Majors remains a disturbing reminder that monsters don't always announce themselves with obvious signs. Sometimes they wear scrubs and smile at patients. Sometimes they work the night shift and help families navigate grief. Sometimes they're the last person you'd suspect, but questions remain. How many others like her are working in healthcare facilities right now, undetected? How many deaths dismissed as natural are actually murders? What warning signs are we missing? To this day, Vermilion Medical Center stands as a reminder of institutional vulnerability. The building was eventually demolished in 2003, replaced by a modern facility with state-of-the-art monitoring systems. But families of victims still gather there each year on the anniversary of Major's execution, placing flowers on the ground where the old building stood, honoring those who died not from disease but from betrayal. And on quiet nights in Prince William County, nurses who worked at facilities during that era still speak in hushed tones about the angel of death, about how she moved through corridors like a shadow, about how death followed in her wake, about how trust, once given to a healer, became the weapon that killed. If this journey through one of medicine's darkest chapters resonated with you, if you find yourself pondering the fragility of trust and the responsibility we place in those who care for our most vulnerable, then consider subscribing to the Untold Hour. There are many more stories waiting to be told, mysteries buried in time that deserve to be examined, truths that challenge our assumptions about safety and institutions. Leave a like if this account provoked reflections that go beyond mere entertainment, and comment sharing your thoughts on how we protect the vulnerable in systems designed for their care. How do we balance trust with vigilance? How do we identify those who would abuse the sacred duty of healing? Until next time, remember that history's darkest lessons are not meant to terrify us, but to illuminate the vigilance required to prevent their repetition. This has been the Untold Hour,